The last 13 years have been the most active in the International Association for the Study of Lung Cancer. In the same time period, we've seen the most advances in lung cancer yet. It's been known as the time of personalized therapy. The decade launched with the 9th World Conference on Lung Cancer held in Tokyo, Japan. The IASLC 2000 Tokyo Declaration on Smoking Cessation was adopted at the meeting.
The one is the scientific highlight was at the time a molecular genetics and also the new strategies for diagnosis, particularly fluorescence bronchoscopy, and the new strategy for surgery. Many new things.
The meeting opened with a concert from the Japanese Symphony Orchestra. In attendance was the Imperial Highness, Prince and Princess Takamoto. Dr. Hayata was the conference president, and more than 2,000 people attended the conference from 64 countries. The same year was the 50th anniversary of the historic article by Peto that described the effect of smoking cessation on the risk of lung cancer death. The research showed smoking cessation could significantly decrease the risk of lung cancer.
Tobacco control and lung cancer are so tied because the risk is so high there. So there's been huge advances in tobacco control over the past several decades. The same time that IASLC has been developing, so has the tobacco control movement. And we've seen awesome successes in some places. Australia, Canada, California, that have instituted strong tobacco control, and they've demonstrated within 3 to 5 years dramatic drops in their lung cancer incidence. Yes, we've seen progress in the treatment of lung cancer, but we know if we can prevent them, since we have around globally about a 15% 5-year survival from lung cancer. But if we can prevent it, that's even better.
In 2003, the 10th World Conference on Lung Cancer was held in Vancouver, Canada. Dr. Nevin Murray was the conference president, and there were more than 3,200 attendees from 77 countries. The following year, the World Health Organization published new rules for lung cancer classification. In addition, scientists discovered a tumor mutation called epidermal growth factor receptor, known as EGFR.
Important development occurs. That was the identification of the mutation in the kinase domain of the epidermal growth factor receptor, or EGFR. Of course, this actually leads to the current sort of concept of classifying lung cancer according to the mutation that actually drive the development of specific type of lung cancer and can also be targeted with specific inhibitors.
The EGFR discovery also propelled research in chemotherapy, as studies show chemotherapy is superior in patients without these mutations. During this time, the role of second-line chemotherapy was also established, as both pemetrexed and erlotinib were shown to improve survival. Erlotinib would also be approved as a maintenance treatment for non-small cell lung cancer patients, and later for patients with metastatic disease. The FDA would also approve afatinib for non-small cell lung cancer patients with EGFR activating mutations. In the area of radiation therapy, SBRT becomes a standard of care in lung cancer patients. In addition,
so we are starting incorporating the functional imaging, like PET-CT scan in radiation planning, to contour what is active tumor rather than what's abnormal CT scan, that help us to minimize normal tissue damage in radiation therapy.
Clinical trials were conducted in the early 2000s defining program death 1 as a novel target.
The positive and negative regulatory elements and cells involved in the immune response were better defined. Regulatory T cells were identified that were not effector cells. They were not fighting the tumor, but they were actually inhibiting the immune response. And various factors were discovered that promoted this inhibitory effect. and prevented it from becoming effective. In fact, it was in the early 2000s where PD-1 was first identified as being a regulatory, one of these regulatory signals.
In 2005, the 11th World Conference on Lung Cancer was held in Barcelona, Spain. Dr. Rafael Rosell was the conference president. There was a record attendance with almost 5,000 participants from 92 countries. The same year, studies showed that lung cancer was the leading cause of death in patients with COPD. Patients using inhaled corticosteroids had lower lung cancer rates. Soon after, studies in the area of surgery were showing why a multidisciplinary approach to lung cancer is critical.
Also, induction chemoradiotherapy or induction chemotherapy followed by surgery are getting more common. And for the surgeon, it is becoming more and more important to evaluate the patients whether they are still a candidate for the surgery. That means we need evaluation of mediastinal lymph nodes after induction chemotherapy. So there are some papers describing the defined method of evaluating the dose of lymph nodes here. I think this is an indispensable part of multidisciplinary approach, including surgery, in 1990s and 2000.
Early in the decade, the IASLC decided to part with the publisher of its journal Lung Cancer and launch a new publication. The first issue of the Journal of Thoracic Oncology was published in January of 2006 under the editorial leadership of Dr. James Jett.
In our first year, we had 300 electronic submissions to the journal. We published 9 issues, which was the plan, and with the plan then in the second year of going then to a monthly issue. So we started out a little slow, figuring that we might not have enough articles to be publishing regularly, and so that transition went well, and every year our journal, I think it doubled the next year from 300 to 600, then from 600 to 800, and the last couple of years we're up between 1,100 and 1,200 electronic submissions per year. And consequently, our acceptance rate has dropped. The first year we probably accepted 70% of the articles submitted, and that gradually has come down because of our limited print pages, and our acceptance rate now is down in about the 20% range.
The journal's impact factor has steadily climbed. In 2012, it was 4.47.
We certainly see our articles being cited much more often in other journals, and we see the data from our journal being presented all the time at national meetings. So all that's a very good sign that we're having more of an influence anyway.
In 2007, the most important advancement dealt with personalized therapy and the discovery of ALK.
In the late 2000s, there is a major oncogene that has been identified, the EML4 ALK. And this identification of this second oncogene that actually identify approximately 3 to 5% of lung adenocarcinoma patients who are very sensitive to a specific inhibitor for the ALK inhibitor. And this is so EGFR and ALK are currently the two biomarkers that are being tested in lung cancer patients to direct specific therapy.
Later, the FDA would approve the drug crizotinib for non-small cell lung cancer patients who are ALK positive. The same year, the 12th World Conference on Lung Cancer was held in Seoul, Korea. The conference president was Dr. Jin-Soo Lee.
More than 4,800 delegates from 84 countries, and the number of abstracts almost 1,300. So it was big success in terms of number of delegations and also number of countries attend, and also it break the previous notion that the conference delegate number of participants will drop when the conference is held in Asia.
Throughout the 2000s, researchers were making progress in the area of low-dose CT screening.
And then the most exciting thing in the last few years, of course, is the study, the National Lung Cancer Screening Trial, showing that low-dose CT decreases lung cancer mortality in high-risk individuals.
The research would culminate, and in 2011, the IASLC Task Force on CT Screening would issue a statement following the National Lung Screening Trial.
I've been doing this for over 30 years, and I would say that the last 5 years have actually been some of the most exciting of that time.
In 2008, scientists were studying genetic variants to assess a person's risk for lung cancer. It turns out, certain racial groups are more susceptible to the disease. A year later, the 7th edition of the TNM classification for lung cancer was published. This edition, originated by the IASLC, included data from more than 100,000 cases. Those cases were from 46 sources in more than 20 countries. The IASLC, along with help from Deb Whippen with Editorial RX, produced educational materials from this data. The staging manual, handbook, and reference cards were translated into numerous languages, bringing enormous exposure to the IASLC.
The IASLC now has a central role in future revisions. We have a responsibility to improve the system progressively. We are expanding the tumours that we cover to include all of the malignancies within the thorax, so pleural disease, thymic tumours, and even esophageal cancer. So it's going to become a thoracic oncology staging project.
The staging materials were distributed at the 13th World Conference on Lung Cancer in San Francisco, California. Held in August of 2009, Dr. David Gandera was the conference president.
It was an experience I'll never forget. It was an incredible amount of work, but it was all worth it. And I've never been more proud of a team, because we had obviously a team of people, our regional committee, to pull it together, because it turned out to be spectacular. And I still have people come up to me and say, you know, that was the best learning experience I had. Also, it wasn't bad that we had the Beach Boys for the entertainment.
More than 6,000 people attended the conference from 85 countries. In 2010, stereotactic ablative radiotherapy, or SABR, is implemented for medically inoperable early-stage lung cancer patients. In addition, radiation oncologists make advances with chemoradiotherapy.
The better technology is to reduce toxicity of our patients who's getting radiotherapy every day. While reducing toxicity, you can further improve their outcomes. If you look back to survival last 2-3 decades, lung cancer, and with radiotherapy, is more than double the median survival times.
The same year, techniques for pulmonologists using EBUS were further defined.
Without any doubt, the most important step was the development and use of the technique of endobronchial ultrasound. So there were probes, and there still are now, that we can use in the bronchoscope to have an ultrasound vision of the airways and also of the lymph nodes outside of the airways. And this again was a dramatic step forward in the diagnosis of peripheral lung cancer, because we could go and look for it by ultrasound in the airways and take biopsies much more precisely. And for the lymph nodes, we could image the lymph nodes by that ultrasound. We could image the lymph nodes in the mediastinum, so that we could take samples of different lymph nodes and thereby coming very close to the capabilities of the surgical mediastinoscopy. So ultrasound certainly was, and the bronchial ultrasound was the step forward of the 80s.
In 2011, the 14th World Conference on Lung Cancer was held in Amsterdam, the Netherlands. Dr. Peter Postmus was the conference president. Nearly 7,000 people attended the conference from 100 countries. The same year, supportive care research showed symptom control remains one of the key unmet needs among lung cancer patients. Symptoms, including coping with distress and physical impairment, are just a couple of the complex symptoms patients with lung cancer face. The drug denosumab was also approved to prevent skeletal problems in patients with bone metastases. In 2012, studies showed that video-assisted thoracoscopic surgery, or VATS, is less costly and safer than a lobectomy. In addition,
that the ACOSOG Z0030 study, which compares lymph node dissection and lymph node sampling. Researchers still don't know whether lymph node dissection or complete lymph node dissection is necessary or not. They are trying to answer these questions.
during the same time, advances were made in the area of immunology.
So in the late 2000s, the use of ipilimumab, the anti-CTLA-4 antibody, was being demonstrated, shown to have efficacy in melanoma. And the thought was perhaps we could translate that into other diseases, and studies were designed in combination with chemotherapy, for example, with lung cancer.
As for the IASLC, the headquarters moved into new offices in 2012, and over the years the staff has grown from 1 person to 6 employees.
I think it's very important that we tell people around the world what is going on in the Lung Cancer Society, what is going on in the science of lung cancer, and it is running very fast. And I really hope we reach out, and I hope we will reach a point where if people want to know what is the hottest in lung cancer science and treatment, they will go to IASLC's website. And
I have been the Director of Membership for IASLC since 2010. I joined IASLC as a staff member in a new position, and since then we've been really pleased to see membership increase by 35% from 2010 to 2013. We have taken steps to improve the database and our collection of information on members so that we can communicate with them better. And we've also improved our retention rate so that we're keeping more of our active members for more and more years.
I joined IASLC in October 2011 as the first Chief Operating and Finance Officer. And it was a very exciting time. The organization had just completed its first strategic plan. And so it's been wonderful to be able to work with the staff and all of our volunteers around the world to really implement the beginnings of that strategic plan.
In 2013, the IASLC published the molecular testing guideline along with CAP and AMP. Dr. Mark Ladani was the IASLC co-author of the publication. The organization also published the Atlas of ALK testing in lung cancer and is preparing for a new WHO classification. Also in 2013, the 15th World Conference on Lung Cancer will be held in Sydney, Australia. The conference presidents are Dr. Michael Boyer and Dr. Kuang Fong.
One of the other important aspects of the meeting in Sydney is that it will be an opportunity to highlight some of the leadership roles taken in Australia in tobacco control. Australia is the first country in the world to have plain paper packaging legislation for tobacco products. That means that when you buy a packet of cigarettes in Australia, it doesn't come with any sort of fancy packaging. It's in a drab olive package, simply with the name of the product on the outside. That's a major step forward, and the opportunity to highlight that and showcase that hopefully will lead to similar initiatives elsewhere in helping curb the tobacco-related epidemic.
You know, every World Lung Cancer Conference is full of science. It's full of good research, full of good education, teaching, and chances for networking. In addition to that, I think Australia offers a very special destination. As you know, it's a very popular tourist destination and a place to go and see. We believe we've got some good climate, some good sights to see, and I think people are very friendly. The medical community are very supportive of this concept, and we're all very excited, and we want to do a good job, and we hope to be able to show everyone, you know, what happens in Australia and some of the lovely sites that we have.
The last 13 years have certainly been the most active for the organization. The board of directors developed a strategic plan, and strides continued in personalized medicine. As Dr. Paul Bunn retires as executive director, a new CEO, Dr. Fred Hirsch, will guide the IASLC into the future.
These days we are moving very fast into personalized medicine of lung cancer. That means a multidisciplinary approach to the management of lung cancer. And that needs very close collaboration between the different disciplines in the planning, in the management of the patients. And I hope that IASLC can facilitate this multidisciplinary approach. So it is my goal trying to bring more and more other disciplines into the organization.